So this presentation is about when do we need interventional treatments in the treatment of in the management of spasticity after spinal cord injury. After spinal cord injury, most individuals with spinal cord injury experience spasticity, but not necessarily all the time. And many individuals who are newly injured often mistake the first movements caused by automatic after spinal shock as a return in motor movement. However, spasticity and muscle spasms may be useful as an advantage to some people which learn to use their spasms to help empty the bladder, do pressure reliefs in the wheelchair, the transfers for dressing, and even stand and walking. Spasticity can also act as a warning sign. If the patient does not normally have spasticity and starts to experience muscle spasms, or if the spasms get worse or even decrease, this may be a warning sign for problems such as pressure injury, urinary tract infection, ingrown toenail, tight clothing, constipation, autonomic dysreflexia, broken bones, humoral cysts, transverse myelitis, and spinal cord stroke. Which are the associating findings now for spasticity? Is increased tone and increased resistance, the increased reflexes, and involuntary muscle spasms and muscle contractions, and of course, clonosis. The consequences of spasticity in the daily living, of course, mobility and transfers are getting more difficult. The hygiene problems, the self-care problems, pressure injuries in contractures, the pain, the sleep problems, the self-esteem, mood and sexual function is reduced due to spasticity. During the rehab evaluation, we need an extensive and detailed history and physical examination, and we need to quantify all findings. And of course, here the team approach is very important from the physical therapist visits, occupational therapists, the orthotists, and the family caregivers will also add some information to the final evaluation. And to find out what is the best intervention for spasticity, we need to use all this information. One thing we need to have in mind is that intervention is usually not only one thing in the management of spasticity. So the treatment decisions are based in some questions. We need to ask ourselves if the spasticity is preventing functional independence, the effect on if it has an effect on functional tasks. For example, spasms are useful, they interferes with positioning and so on, or interferes with sleep, interferes with normal activities of daily living, hygiene, or self-care. Is the spasticity painful? What is the location of spasticity? What is the distribution of spasticity? The severity of quality of pain due to spasticity? And what other treatment options have already been tried? And what were the results from these options? The decisions are made based on the severity of the problem, the scope of the problem, because spasticity can be local, regional, or generalized, the cost-benefit ratio, the risk-benefit ratio, limitation and side effects of the treatment, and the overall health of the patient and goals of the patient and the caregiver is very important in decision-making. The therapeutic steps we're following to manage spasticity, and here we're talking about the control of the spinal origin spasticity, which is progressing from less to more invasive treatments, more conservative treatments, including elimination of nociceptive stimuli, rehabilitative approaches with physical methods and occupational therapy methods like splint and casts are tried in at first approach in combination with this efforts treatment of spasticity, and currently the most patients may receive oral spastic drugs and which are very useful also. And otherwise, we need to proceed to more invasive treatments like neurolysis, orthopedic procedures, and neurosurgical procedures. Regarding rehab interventions, physical and occupational Treatments are the first action taken to treat spasticity. Flexing and arm activities help to keep the joints mobile and prevent muscles from shortening. The use of orthotics can also help muscles in a stretch position. This improves range of motion, allowing for safer movement and better mobility. Of course, the position is very important. Nursing things, the positions in bed in a wheelchair. Modalities may also be helpful, like heat for relaxation or cold for inhibition, spasticity. And we need to note that physical therapy treatment alone may be insufficient to overcome the effect of increased muscular tone, like spasticity or its mechanical consequences, particularly in moderate to severe spasticity. So this slide presents the spectrum of care from the management of spasticity. In the center is the patient, and around are all the approaches we can use, like the prevention of nociception, rehabilitation approach, and so on. But we need to know that the conservative treatments are not always sufficient. 30% of patients with spinal spasticity are not effectively treated with oral medications. If adequate control of spasticity and spasm is not achieved with each successive treatment option, more invasive therapies are tried. Orthopedic and musculoskeletal surgery can be used to lengthen tendons or muscles, thus reducing tension, pain, and spasticity. Neurostimulation, neuromuscular blockades, and other neurodestructive techniques are also used. Neurodestructive techniques are indicated as the last resort in focalized spasticity that is not amendable to intrathecal baclofen or for excess or widely extended diffuse spasticity due to the lack of reversibility of these conditions. When we need to summarize some other non-pharmacological interventions for spasticity, we need to have in mind that hypotherapy may result in a short-term reduction in spasticity. The combination of neural facilitation techniques and baclofen may reduce spasticity. Rhythmic passive movements may produce short-term reduction of spasticity. Prolonged standing or other methods of producing muscle stretch may result in reduced spasticity. Electrical passive pedaling systems may result in short-term reduction in spasticity. Active exercise interventions such as hydrotherapy, functional electrostimulation, assisted cycling, and walking and robotic-assisted exercise, including specific exercise combined, may produce short-term reduction in spasticity. Electrical stimulation applied in individual muscles may produce a short-term decrease in spasticity. However, there is also some concern that long-term use of electrical stimulation may increase spasticity. Ongoing TENS transcutaneous electrical nerve stimulation programs result in short-term reduction in spasticity, which may last up to 24 hours. And the use of TENS and standard physical therapy show the reduction in clinical spasticity in the subacute phase of rehabilitation, which may be important. Penile vibration and rectal probe stimulation may be effective of reducing lower limbs muscle spasticity for several hours. Other forms of afferent stimulation, including taping, massage, therapy, whole body vibration, may result in immediate spasticity reduction that require more research to understand effects and intervention parameters. Spinal cord stimulation may provide spasticity relief over a few months, but long-term effectiveness and feasibility is less certain. And repetitive transcranial magnetic stimulation may provide spasticity relief and improve walking speed over the short term, but long-term effectiveness is unknown. Treatment with intermittent burst stimulation finally is likely to reduce upper extremity spasticity for up to 1 week. All this means can be used as a non-pharmacological countermeasures for spasticity. Coming now to the pharmacological interventions For spasticity, we have three categories. The first one is drugs, and the second one are some kind of injection, and the third is the intrathecal baclofen pump. Starting with the drugs, we have the central acting drugs, meaning the first category here is first drug of choice is baclofen. We also can use the alpha 2 agonists like tizanidine and anticonvulsants like benzodiazepines, diazepam, clonazepam, and also gabapentin, this gabapentin, which is also in nice guidelines from multiple sclerosis. The second category here are the peripheral active drugs. We have only one control, sodium. And coming now to the injections, botulinum toxin and phenol alcohol injections, respectively. And the third is the intrathecal baclofen pump. Medical treatment options depend to some extent on the pattern, the distribution of spasticity. In intramuscular botulinum toxin injection, or less commonly and rarely now in nowadays, nerve blockade with phenol in aqueous solution are the pharmacological treatments of choice for focal spasticity. If spasticity causes multifocal problems, botulinum toxin may again be helpful, but dose limitation may reduce its long-term effectiveness, and additional strategies such as intrathecal baclofen or a combination of botulinum toxin and phenol can be considered. Oral antispasmodic agents like baclofen, tizanidine may be considered for generalized or segmental spasticity, but frequently carry the unwanted side effects. Furthermore, it is not uncommon to have a mixed pattern of spasticity with focal and generalized elements, and in practice, interventions are often combined. For example, botulinum toxin may be given to target a specific problem, example, difficulty maintaining hand hygiene, while baclofen is prescribed to manage a background of spasticity. So oral baclofen may reduce spasticity, but is inferior to botulinum toxin injection. Diazepam is also effective. Tizanidine is likely useful, botulinum neurotoxin improves focal mass spasticity. Phenol blocks may improve pain, range of motion, and function related to shoulder spasticity in individuals with tetraplegia and may reduce hip-adapted spasticity in individuals with paraplegia and tetraplegia, and bolus or long-term intrathecal baclofen decrease spasticity and may improve functional outcomes with low complication rates and is a cost-effective intervention. Coming now to a review regarding spasticity treatments, pharmacological interventional approaches by Eric Chang, co-authors, and finalize a conclusion that the interventional therapies for the problem of procedural errors, difficulty in finding a provider who is trying to perform the procedure, and have other further complications. However, it may provide greater control of spasticity with few systemic side effects, and if patients are compliant and can tolerate the procedures are very good. So a decision tree for pharmacotherapy may be the following. The oral medication is at the beginning, we start with oral medication. If we have inadequate control of spasticity or undesirable side effects, we proceed. In case of the spasticity presented in a functional unit with local injection botulinum toxin, or in case with the multi-signal spasticity to intrathecal baclofen via implantable pump, botulinum toxin and baclofen pump may be used in conjunction. The main side effect of this baclofen, tizanidine, diazepam is sedation, and so we can escalate the dose more if our patients have those side effects. Once we have exhausted those treatment options, and it's still refractory and our patient cannot tolerate more antispasmodic medications because of sedation, then we can consider intrathecal baclofen. Some dosage of oral medication commonly used for spasticity are baclofen 5 milligrams 3 times daily. We can escalate the dose to 6 to 80 milligrams per day in divided doses. Of course, we have the adverse effects of muscle weaknesses, sedation, dizziness, and withdrawal syndrome. The same adverse effects are are for tizanidine. We can start with tizanidine with 2 milligrams daily. We can maximum dose to 36 milligrams daily in divided doses. For the diazepam, the same adverse effects. Starting dose 2 milligrams twice daily or 5 milligrams at bedtime. Escalate to 40 to 60 milligrams daily in divided doses. And now then we pass to dantrolene. We said before that is the only drug which is peripherally acting. Another drug, here the problem is the potential irreversible hepatotoxicity, which requires regular monitoring and also the same weakness and sedation. We can start dantrolene with 25 milligrams and we can escalate to 100 milligrams 4 times daily. Then we pass to clonidine, 0.05 milligrams twice daily to 0.1 milligrams times daily. But as we know, clonidine is often used for arterial hypertension, so this can cause hypotension, bradycardia, dizziness, and so on. And finally, gabapentin, 100 milligrams 3 times daily, escalate the dose to 3,600 milligrams daily. Of course, the same events. The next move is to move on to nerve blocks. With phenol and alcohol, the indications, of course, the local hypertonicity. This facilitates serial casting and differentiate spasticity from a contracture. Phenol is reserved for regional lower limb spasticity involving large muscles, for which treatment with botulinum toxin injections will not be appropriate due to the need for high doses of botulinum toxin. Coming out botulinum toxin, we can use it in spasticity that is centered on one area or a region of the body, may respond to treatment with this toxin injected into stiff muscles to temporarily block the contraction. And this should be started early after spasticity occurs and before soft tissues begin to shrink. At the later stage and even at the chronic stage, when an abnormal motor pattern is established, we can inject botulinum toxin in selected key muscles to modify movements that amplify the disorder. When do we need more interventional treatments in management of spasticity? Of course, the answer is simple: when the non-interventional are inefficient. And which kind of treatments are these? Individualized treatments with intrathecal baclofen pump. While it has been standard practice to wait a year after injury for a pump to be implanted, there are cases when implantation is recommended earlier if advantages outweigh disadvantages. And the time with intervention cannot be absolute, as it depends on the patient's clinical condition and overall therapeutic plan. The criteria are here failure of Perros therapy to manage spasticity, increased spasticity with negative consequences, pain, and reduced ability to perform activities of daily living or activities cannot be adequately performed, compromised by spasticity, like a setting in mainly home. So we can have the surgery, which is reversible, to have the pump with a reservoir. The medicine is pumped through a small catheter tube directly to the fluid surrounding the spinal cord. The pump is implanted subcutaneously in the abdomen. The catheter tunneled to lumbar region, distal, and inserted intrathecally. Programmable pump allows simple or complex programming for boluses and requires periodic refills with a drug, and the pump will be replaced at the battery end of life. So, of course, there are some disadvantages with this pump. This requires surgery to implant the pump, is expensive, tubing can become disconnected or kinked, and the risk of infections, baclofen overdose, pump dysfunction, symptoms of withdrawal are also present. Advantages: medicine is sent directly to the nerve cells, the dosage can be adjusted, less medication is needed, which reduces side effects, and reservoir can be easily refilled when needed, and surgery is reversible in this situation. So if we need to treat severe spasticity of cerebral or spinal origin, which is the case here. We usually consider for intrathecal baclofen therapy for diffuse spasticity of the lower extremities when oral medications are ineffective or not tolerated, and also need to control upper extremity spasticity. We need to put the placement the catheter higher. A very effective therapy, particularly spasms, relatively safe, well tolerated, adjustable, and potentially reversible. The discontinuation of oral and spasm medication may increase energy level. Here there is a review published by Ditch with 70 studies reported on the efficacy of baclofen in reducing modified Ashworth score, Ashworth scores in the population with SCI, specifically 350 individuals. Of those, 6 studies reported a reduction of 1 grade in modified Ashworth score with oral baclofen use in 206 individuals, and 11 studies reported a reduction of 2.1 in modified Ashworth scores with intrathecal baclofen use in 90 individuals, demonstrating increased efficacy with intrathecal administration of baclofen. Of course, if all this fails, then we have the surgical techniques tested. We can use very often in rehabilitation medicine techniques, surgical techniques like tendon lengthening on release or transfers, and neurotomy, rarely selective posterior rhizotomy. All these surgeries are permanent new situations. So to conclude, spasticity needs to be managed. There are PMI interventions for regional and general spasticity, and the management is associated with rehabilitation goals and the stage of recovery.